Welcome back to the deep dive. Our mission today is highly targeted. We are building the ultimate high-yield module on the anatomy of the head, neck, and brain. And this isn't just about, listing a bunch of structures. This is about delivering the most critical, scientifically rigorous knowledge from our source material.
The really core stuff.
Exactly. The stuff that explains the symptoms, the pathways that harbor major clinical risk, and, the anatomical connections you absolutely need to nail down before walking into any rotation.
It's a vast amount of material for sure, but we're prioritizing function over just like rote memorization. Our focus is distillation, giving you those clear, memorable insights and clinical nuggets.
Okay.
If you understand why a structure is vulnerable or how a pathway connects two seemingly distant parts of the body, you are well on your way to mastery.
Okay, let's unpack this and start with the armored foundation, the cervical spine. Structure truly dictates function here, and the cervical vertebrae are instantly recognizable. They have a feature the thoracic and lumbar vertebrae just don't have. I'm talking about the foramen transversarium, that small hole, that perforation in the transverse process. If you're a keen learner, why is that specific hole a 5-star review item?
Well, what's fascinating here is that this tiny protected tunnel exists primarily to safeguard a critical neurovascular highway.
Okay.
The foramen transversarium transmits the vertebral artery, which is a major blood supply to the brainstem, the corresponding vertebral veins, and the sympathetic plexus.
So it's crowded in there.
It is. And this arrangement occurs from cervical vertebrae C1 down through C6. This protection is vital because you have a major artery running right through bone.
And when trauma bypasses that protection, the consequences are, they're immediate and severe. If we look at cervical fractures, often from high-velocity impacts like car accidents or sports injuries, the risk goes way beyond just a broken bone.
It does, yeah. A fracture in this region is a true medical emergency because the fragmented bone can cause compression of the delicate spinal cord. This can result in two outcomes: spinal shock, which is a transient loss of motor and sensory function, or, tragically, irreversible, quadriplegia complete, permanent loss of function in all 4 limbs.
And what are the signs you'd look for?
Clinically, you might see radiating pain from the neck into the shoulder or arm. That's your indicator that the nerve roots themselves are being pinched by those bony fragments.
So the takeaway on the spine is clear. Immobilize for the cord, but never forget the risk to the vertebral artery. Now, if the neck is about a protected vertical column, let's look at the skull base, which is basically a horizontal bony roadmap for every other structure entering or exiting the cranium.
Right. And if we connect this to the bigger picture, the skull base, formed by the occipital, sphenoid, and temporal bones, is punctuated by specific foramina that are essential landmarks. You just have to know them.
For example,
on the greater wing of the sphenoid, you find the foramen ovale and the foramen spinosum. We also have the carotid canal, which allows the internal carotid artery to enter the cranial vault, and the stylomastoid foramen, which is the exit point for a crucial cranial nerve.
We've talked about bony armor. Now let's examine where the soft tissues are surprisingly vulnerable. Let's move to the scalp. It seems simple, but it contains the layer that gets dubbed the dangerous layer of the scalp, the loose areolar tissue.
That name is very well earned. This layer is clinically significant because of the unusual attachments of the musculature.
How so?
The frontal belly of the occipiter frontalis muscle, which spans the forehead, has no bony attachment in the front.
Oh, interesting.
Which means the loose areolar tissue is continuous with the soft tissue spaces around the eyelids.
So if someone sustains a massive scalp laceration or a severe bleed, the anatomy means that gravity just dictates where that blood is going to pool.
Precisely. That anatomical continuity explains the practical example everyone has seen. Why bleeding high up on the scalp can track downward and present as a swollen, discolored black eye.
Right.
But that's just the messy part. The dangerous part is the direct connection this layer has to the brain itself.
Tell us about that mechanism. How can a simple cut become life-threatening?
It's all about the plumbing. This loose layer contains numerous valveless emissary veins.
Valveless, so the blood can flow both ways.
Exactly. Because they lack valves, they create a two-way street connecting the veins of the scalp directly to the major intracranial venous sinuses. So if you have an infected scalp laceration, that infection can spread straight into the cranial cavity.
Wow.
And you risk severe conditions like meningitis or dural venous thrombosis. It's a literal backdoor for sepsis to reach the brain.
That is the essence of high-yield anatomy right there, connecting a small surface injury to massive intracranial risk. Moving on to the face, the main blood supply is also a key surface landmark.
It is. The facial artery, a branch of the external carotid artery, is crucial. It enters the face by turning sharply around the lower border of the mandible.
Okay, and you can feel this.
You can. You can feel this entry point right at the anteroinferior angle of the masseter muscle. That's a common clinical palpation point because you can press the artery against the bone to check the pulse.
And while we're on vasculature, we need to note the venous drainage, specifically that anastomosis near the eye.
That connection at the medial angle of the eye links the facial vessels, part of the external carotid system, to the orbital vessels, which are part of the internal carotid system.
So another potential pathway for trouble.
It's another path that allows blood flow and potentially infection to drain into the orbit and back toward the skull.
Let's pivot to sensation. The trigeminal nerve cranial nerve 5, CNV, is the major sensory driver for the face. We need to know where its three sensory divisions emerge.
Right. The trigeminal nerve supplies sensation to the skin of the face, the anterior scalp, the mucous membranes of the nose and mouth, the teeth, even parts of the dura.
So it's a huge territory.
Huge. When studying, you really want to focus on the foramina. The maxillary division gives rise to the infraorbital nerve, which emerges from the infraorbital foramen. The mandibular division gives the mental nerve, emerging from the mental foramen.
And knowing those specific bony exit points is what makes localization possible. For example, if someone breaks their jaw, a really common facial trauma, which nerve is at risk?
A fracture of the mandible can easily damage the inferior alveolar nerve, specifically its mental branch, as it exits that mental foramen.
And the patient would notice that immediately.
Immediately. If that nerve is compromised, the patient will experience numbness or tingling in the distribution of that nerve, which is typically the lower lip. The location of the trauma immediately dictates the neurological deficit.
Stepping inside the cranium, the brain is wrapped by the three protective meningeal layers, dura, arachnoid, and pia mater, and the subarachnoid space, floating with cerebrospinal fluid, or CSF, that acts as the brain's shock absorber. Right?
Exactly. The CSF buffer is critical for distributing and equalizing pressures within the skull. To circulate, the CSF leaves the ventricular system, specifically the fourth ventricle, via the median and lateral apertures, and enters that protective subarachnoid space.
Here's where it gets really interesting and, frankly, a bit terrifying. The cavernous sinus. This anatomical intersection is a huge clinical red flag because of everything passing through it.
And this raises a really important question. Why is this structure so crucial? The cavernous sinus sits laterally to the pituitary gland and the sphenoidal air sinus.
Okay.
And you have to clearly separate the structures running within the sinus, which are separated by endothelium, from those running in the lateral wall.
Right, so what's running inside the venous blood?
Within the blood, you have the internal carotid artery and the abducens nerve, cranial nerve 6.
So that abducens nerve, seen in the sinus, is incredibly vulnerable to compression or pathology right there, just given its location.
It is highly vulnerable. And then running in the lateral wall, safely separated from the blood but still exposed to pressure, are the oculomotor, CN3, the trochlear, CN3, and the ophthalmic, V1, and maxillary, V2 divisions of the trigeminal nerve.
So when infection reaches this site, the result is cavernous sinus thrombosis, or CST. How does a seemingly distant infection, say from a tooth, actually get to this deep, protected location?
CST often results from infection spreading from the midface or a deep abscess, via communicating vessels like the ophthalmic veins or the pterygoid venous plexus, which all drain into the sinus. The symptoms are a perfect reflection of the anatomy we just covered.
We get a severe headache from meningeal irritation, obvious periorbital swelling from the venous congestion, and then the key neurological deficits.
Yes, the compression or inflammation directly affects the nerves we listed. You get double vision or diplopia, often due to paralysis of the abducens nerve, and you'll also see sensory loss or facial pain from pressure on V1 and V2 embedded in that wall.
Let's talk about endocrine control and vision. The pituitary gland, housed securely in the hypophyseal fossa, is connected superiorly to the hypothalamus. The importance of its location is really defined by its neighbor, the optic chiasma.
Absolutely. When you have a large pituitary adenoma, a common type of tumor, it expands superiorly.
Upwards.
Upwards. This expansion causes direct pressure on the adjacent optic chiasma. And this structure is where the nasal fibers from both retinae cross the midline. These nasal fibers carry information from the temporal or lateral visual fields.
So if you compress those crossing fibers right in the center, you lose peripheral vision in both eyes. That leads to the characteristic bitemporal hemianopia.
That's a perfect example of anatomy dictating pathology.
Okay, now moving down to the spinal cord. Its endpoint is essential knowledge for any clinical procedure.
It is. The actual spinal cord terminates quite high, specifically at the intervertebral disc between L1 and L2. Below that, the cord tapers into a leash of nerve roots known as the cauda equina.
So what's the clinical relevance of that termination point?
The high termination means that a lumbar puncture, the safe procedure used to collect cerebrospinal fluid, can be performed well below the L1 or L2 level, usually in the lower lumbar vertebrae, without any risk of injuring the spinal cord itself. You're only pushing past the individual nerve roots.
Finally, we have to briefly review the major ascending and descending tracts. For the learner trying to localize an injury, the most important thing is knowing where these tracts cross the midline. Can you give us the basic principle?
The basic principle is that crossing points vary drastically depending on the function. Motor fibers, primarily carried by the corticospinal tracts, generally cross high up in the pyramids of the medulla before descending down the opposite side of the spinal cord.
Okay, so motor and fine touch cross high up in the brainstem. What about the fast track sensation of pain and temperature?
That pathway, the spinothalamic tract, is unique. It crosses immediately upon entering the spinal cord, often at the level of the lesion itself, and then it ascends contralaterally on the opposite side of the spinal cord. Understanding these three distinct crossing points is the key to solving virtually any localization puzzle.
That brings us to the end of our deep dive. We've established a rigorous foundation covering bony protection, surface danger zones like the emissary veins, vulnerable cranial contents like the cavernous sinus, and the functional neuroanatomy of the pituitary and spinal cord tracts.
Now, to truly synthesize this knowledge and apply the crossing points we just reviewed, we have a challenge for you, the learner.
Imagine a patient who sustained a partial injury to the right side of the spinal cord at the T10 level. This clinical presentation is known as Brown-Séquard syndrome. Based on the pathways we just discussed, here is your challenge. Why would this patient experience paralysis and loss of vibration and position sense on the right side, ipsilaterally, below the injury?
But lose the sensation of pain and temperature on the left side, contralaterally, below the injury. Visualize those three distinct crossing points: motor, proprioception, and pain temperature, and connect the damage on the right to the resulting deficits on both sides of the body. If you can solve that puzzle, you have fully integrated this high-yield neuroanatomy. Good luck and happy learning.